Hello, I'm Nora Hanna, Chief Engagement Officer at Sun Health, and I'd like to welcome you to this episode of Coffee Connections. We created this series to help you stay connected to the latest developments in healthcare and wellness by hearing directly from experts in our community. The Sun Health Foundation is committed to ensuring that this region has access to the most recent medical and technological advancements, and that we attract the brightest and best practitioners for care. To that end, we are the exclusive philanthropic partner to Banner Boswell and Banner Del E. Webb Medical Centers. Our mission is to empower others to live longer, healthier, and more purposeful lives. So we're excited to be able to offer you this unique access to these valuable expert resources. Thank you for joining us and enjoy the presentation.
Our story goes back, nearly 60 years when a group of thoughtful, community-minded Sun City residents came together with a big idea to build a hospital for their growing retirement community. Thanks to their vision and land donated by Mr. Boswell, Boswell Memorial Hospital was created. As the area kept growing, the community stepped up again about 18 years later to help build the Del E. Webb Memorial Hospital, where we are today. Sun Health operated both hospitals until 2008 when they transitioned to Banner Health. And ever since, Sun Health Foundation has proudly served as the exclusive philanthropic partner for Banner Boswell and for Banner Del E. Webb Medical Centers. Additionally, we support the Banner Sun Health Research Institute. However, beyond the hospitals, our donors make programs possible through the Center for Health and Wellbeing, from free health and wellness classes to our Memory Care Navigator program, which is amazing. This program walks families through the dementia journey. We also support nursing scholarships that help grow the next generation of caregivers. So all of this work supports one big goal: helping our community live healthier, longer, and better. And that's what brings us here today. Coffee Connections is our way of keeping you plugged into what's happening in health and wellness, straight from the experts, and giving you the chance to meet the incredible providers serving our community with the hospitals we support. With that, I'd like to introduce our presenter. Dr. Broussard is a board-certified thoracic surgeon dedicated to delivering patient-centered care grounded in education, clear communication, and respect. His expertise spans both open and minimally invasive surgical techniques, including endoscopic, laparoscopic, thoracoscopic, and robotic approaches. He specializes in managing a wide range of thoracic and upper abdominal conditions, from lung and esophageal cancers to complex airway disorders, thoracic outlet syndrome, mediointestinal diseases, and diaphragm and chest wall conditions. Dr. Broussard completed his thoracic surgery training at Massachusetts General Hospital. Following a residency in general surgery at UAB Hospital, he earned his medical degree from LSU Health Sciences Center in New Orleans and is board certified in both general surgery and thoracic surgery. Outside of the clinical practice, Dr. Broussard enjoys spending time with his wife and children, as well as staying active through exercise, golf, fishing, and college football. Fun guy.
Great. Thank you, Claudia. And it's an honor to be here. I've spoken at a couple of Sun Health events now, and it's always a pleasure. And I just want to reiterate the help that Sun Health gives us clinically. I mean, a lot of the things I'm going to talk about today are technologies and things like that Sun Health has directly contributed so that we have these state-of-the-art equipment in our hospitals. So very appreciative of Sun Health. So I was asked to talk about lung cancer today, and we're with the topic of what we need to know and why there's more hope than ever. And I do think there is more hope than ever, but what we need to know, there's a lot to know about lung cancer. So I'm going to try to go through lots of things. I save the good stuff at the end. That's the surgery stuff. You're going to get the biased opinion of the surgeon today. So thank you all for coming. So first, I just prove to you hopefully that I'm qualified to be up here and I'm not like a teenager or something, like I usually get questioned about. So I am from Louisiana originally. I went to LSU in New Orleans Medical School. A couple of just side notes, may have heard of a storm called Katrina. That was 6 weeks into my first month of medical school. Yeah, first month. So anyway, we all made it through that. But then I went on to do my general surgery training at University of Alabama, Birmingham. General surgery training is 5 years. I did an extra 2 years in the middle of that where I did basic science research in surgical oncology. And so I did mouse experiments and cell culture and all kinds of different things there. And then went on to Mass General Hospital where I did my cardiothoracic surgery training. And that was another 2.5 years. So I guess if you're adding that up, I don't know the numbers. Yeah. So this picture, this is my wife and I actually at graduation day in Boston in front of the Bullfinch building. I don't know if anybody's ever been to Mass General. It's a very historic hospital. One of the first uses of general anesthesia ever was actually in the ether dome at the top of that building. So I am board certified in general surgery and thoracic surgery. And my function and banner is that of a general thoracic surgeon. Technically, we are trained to do cardiothoracic surgery. I leave that to my very esteemed colleague, Dr. Cathuria, who you guys probably may have heard that name before, but Dr. Cathuria is a very, very good friend and surgeon. All those credentials, I think, are great, but this is one of my proudest credentials, I'd say, is that I'm speaking to you today not only as a surgeon, but also as a cancer survivor myself. So this was me, I was 16. That's girlfriend at the time, if you look, also my wife. And so, anyway, I've shared my story with Sun Health many times, but that's just a little side note. Today, so we're going to talk about lung cancer. So I just trying to go through some statistics, general overview. We'll go over all the different testing that you might need to go through. And ultimately, I'm going to try to touch on briefly at each of the different treatment specialties, like medical oncology, radiation oncology, and then obviously thoracic surgery. And then I'd like to hopefully end with a little bit of what we're doing at Banner D. Anderson to kind of help put all this together for our patients, okay? So lung cancer is not a great cancer in that it is one of the most deadly, it is the actually most deadly type of cancer you can get worldwide. With death rates exceeding colon cancer, breast cancer, prostate cancer. Part of the issue with that is delayed in diagnosis, and I'll come back to that in a minute. But there's two main classifications of lung cancer, one of which is small cell lung cancer, and you can see it only makes up for about 15% of all lung cancers, and then the other classification is non-small cell lung cancer, and then that's further divided into what we call adenocarcinoma and then squamous cell carcinoma. You may have heard of squamous cell carcinoma. A lot of people get skin cancers that are squamous cells. They get burned off or scraped off or whatnot. This is the same type of cell, but it's in your lung. And so obviously, not to, all cancer is bad, but when it's squamous cells in your lung, bigger deal than, let's say, on your skin. Okay, I want to point that out. These are some of those statistics I was talking about. I'm sorry if they come in kind of small, but what I want to iterate is we think about lung cancer in general and 5-year survival rates. And this is data from 2015 to 2021, so a little bit dated, but you can see for early stage or localized lung cancer for non-small cell, the 5-year survival rate is 67, almost 70%, whereas if you compare that for the small cell lung cancer at the bottom, it's 34%. So if you're comparing the non-small cell to the small cell lung cancer, non-small cell definitely has a better prognosis, whereas small cell lung cancer is much more aggressive. And unfortunately, it's one of those that can come back multiple times even. One of the biggest things we can do, I would say, as I said in my opening slide, to bend the curve, as I call it, to improve survival rates, is screening. And so I know we're very big on mammogram and breast cancer screening and colonoscopy and colon cancer screening, but screening for lung cancer also exists. And so there are specific qualifications you need to get the lung cancer screening CAT scan. And it is a low-dose CAT scan. This isn't your normal CAT scan. It gives us still great pictures, but it's not the same radiation dose. It's actually much lower. Okay, and you can see the qualifications there. So if you're 50 to 80 years old, if you've smoked more than 20 pack years of smoking history, so that's 1 pack a day on average for 20 years, or you can say half a pack for 40 years, or 2 packs a day for 10 years. You can do the math. And you're a current smoker or quit within the last 15 years, you qualify for a free, completely free low-dose CT of your chest. And so those curves that we're showing over there on the right show that basically screening matters. And unfortunately in lung cancer, as I mentioned, it's found too late sometimes, where it's more progressed. And so screening has absolutely helped people where we're finding earlier and earlier stage lung cancers, which then get better survival rates and better prognosis. This slide is, I know, kind of busy with a bunch of different pictures, but if you were in a position where you, let's say you or a family member had lung cancer, or a lung nodule at least that was going to be investigated for lung cancer, there's many tests that we have to do. So lung cancer is one of those types of cancers where one of the common things I hear from patients is, oh, another test. Yes, there's unfortunately a lot of things we have to figure out to properly stage you for a lung cancer. And so at the top there is a CAT scan. The picture just below the CAT scan is a PET scan where you see that orange glowing mass in the lung. And then the bottom right is a brain MRI. So these are 3 very common tests that we would do when working up a patient with a diagnosis of lung cancer. Over there on the right side, or I guess left side of the screen, that's a pulmonary function test apparatus or lab. And so pulmonary function testing is very important as a thoracic surgeon because I need to know how good your lung function is. So if I'm going to take you to surgery, I want to make sure that we're doing the right thing for you and your lungs are going to be good after surgery. Also a part of the workup and staging for lung cancer is a lot of times we need tissue biopsies. You need a biopsy. And these 2 pictures here are showing the most common ways we do lung biopsy. So this picture on the left there, that's a CT-guided lung biopsy. That'd be done here by one of our interventional radiologists, like Dr. Hoglund. And so you lay down on the table, they use a CAT scan, basically the CAT scan technology, and then you can see they pass a needle straight through your chest wall into the tumor to get a tissue biopsy. Or there's the way on the right side of the screen. This is probably one of the latest, greatest. Sun Health actually was directly involved with getting us this technology. So this is what's called a robotic bronchoscopy. And so it's done, made by the Intuitive Surgical Company, the same company that provides us with our surgical robot technology. This bronchoscopy platform basically merges a camera, so like you would a normal bronchoscopy, which is a camera like a colonoscopy or an endoscopy, but it merges that technology with your CT scan. And so it allows our pulmonologist to essentially, with very close precision, to drive the camera into your lung, no cuts, no pokes anywhere on the outside of your body, and then biopsy the lung all from the inside. And so that is a very cool technology that I would say there's many other benefits of going that route as well, in that they can also do lymph node staging all at the same time. So most of our patients who do go that route kind of get a twofer. You get your biopsy and you get your lymph node staged all at the same time. Not to knock our radiology colleagues, they do an excellent job. And sometimes this is the best way to get a biopsy. But then you would have to do a secondary procedure sometimes to get your lymph nodes evaluated after the CT-guided biopsy. So just want to point that out. Another busy slide, and I'm just going to try to, once again, keep it high level, which is staging is very important, I would say for any type of cancer, but especially lung cancer. As clinicians, if we don't know what stage you are, we can't give you the right treatment. And so every stage has a separate treatment algorithm or treatment options. And so when patients do, lament, oh, so many tests we have to do, I try to remind them that by doing all these tests, you're making me more accurate in staging you, which is going to get you on the best treatment, which ultimately is going to give you your best chance to beat the cancer. And so we just try to reiterate that. And as I'll say, show you here in a second, how we try to expedite those things. But lung cancer, 4 stages, stage 1, 2, 3, and 4. Stage 1 being early stage, stage 4 being advanced stage. So stage 1 means it's basically just in the lung. Stage 2 could mean it's in the lung and maybe a lymph node or another spot in the lung. Stage 3 means it's in the lung, but also some lymph nodes farther away from the lung. And then lastly, stage 4 means it's in the lung, but probably somewhere else in your body. Okay. So now, like I said, and hopefully I'm doing okay on time, I'm going to talk about medical oncology, and this is my disclaimer: I am not a medical oncologist, but I will do my best to explain what our colleagues are doing. And I find my patients like the way I explain medical oncology because I explain it like a patient, because I don't do medical oncology either. So most people think of medical oncology and they think of chemotherapy, right? And chemotherapy is, to this day, still one of the main treatments in medical oncology. And when I say chemotherapy, I'm speaking specifically of what I would call the traditional chemotherapy. And for lack of a better term, once again, my kind of dumb surgeon way to think about this, chemotherapy is cytotoxic. Cyto meaning cell, toxic meaning toxic to the cell. And so that's why with traditional chemotherapy, as you can see in the bottom right there, you can have lots of side effects, right? Because it's not only hurting the cancer cells, but it's also hurting some of your native cells as well. And so that could mean losing your hair, that could mean GI upset or symptoms, low cell counts, like your white blood cell count, red blood cell count, etc. And, for better or for worse, it is still one of the mainstays as part of our medical oncology treatments for lung cancer. But I would say the more exciting things, as I'll talk about next, the next thing would be targeted therapies. And so targeted therapies, once again, the way my brain thinks about targeted therapies is a whole lock and key phenomenon. So to understand targeted therapies, you have to realize about half, and I'll show you on the next slide here, about half of lung cancers form because of an acquired genetic mutation. So a mutation in your DNA where a gene gets altered, and that gene is basically the gasoline on the fire that kind of jumpstarts the cancer, okay? And there's, as I'll show you, many different gene mutations that you can find for lung cancer. So just as an example, ALK, ALK, EGFR, KRAS, RET, BRAF, these are all different gene mutations that can be the basically drivers of these types of cancers. And so what the pharmaceutical companies do is think about the gene as the lock. The pharmaceutical company is trying to find the key. And so they want to find different keys that will unlock these gene mutations, which will then kill the cell. Okay? And so that's why you see all these different drugs are either on trial or have undergone clinical trials in lung cancer. And so many of these drugs are pill form. So a lot of times I get asked, well, can I take a pill for that type of treatment? Many of these targeted therapies are the pill form that you hear about that might be prescribed. And then the next thing, probably, I would say, in the last 10 years of all cancer, probably the biggest advancement or improvement in outcomes is immunotherapy. And a lot of people may have heard of that or heard friends or family talk about immunotherapy. But immunotherapy is just what it sounds like. It uses your immune system to fight the cancer. And my best way of explaining that or understanding that is essentially, I hate to say this and I don't want to scare anybody, but our bodies, we form cancers every day. We all do. And our body uses its own immune system to not let that progress, to not let that happen. And what I mean by cancer, I just mean a mutation or just a genetic something happens in your cell makeup every day. And your body has an immune system that is built to fight that and to recognize it and to kill that so it doesn't form anything bad. When a cancer forms, it finds a way around that policing system that your body has to get around that. And so what the immune therapy does is it basically allows the immune system to recognize that as a foreign invader again, or as a bad cell, and then it attacks it. And so that's what immune therapy does. It basically allows your immune system to recognize those cancers that it previously didn't recognize. and then it attacks. Okay. I'd say the benefit of immunotherapy, as it's shown on the right, is pretty selective. So it's not, yes, you can have some autoimmune type flare-ups, some pneumonitis or inflammatory type things, but in general, immunotherapy is great because it really spares your normal tissue. It's not supposed to attack or hurt your normal cells like traditional chemotherapy does. And I thought these are just an example of some great statistics that these are 5-year survival rates for metastatic melanoma, metastatic lung cancer, myeloma, and liver cancer. And you can just see the pre and post immunotherapy difference, right? So in lung cancer over there, metastatic lung cancer, 5-year survival rate is 2% in the studies they looked at. And when they added immunotherapy, it's 10% now. Now, that still is not good, okay? But when you're starting at 2%, that's phenomenal, okay? And same for melanoma, myeloma, liver cancer. These are all cancers that are very deadly and really had no good treatments prior to that. Especially, I would point out melanoma and liver cancer. And so you can just see the drastic improvements with the immunotherapy. I would say one of the challenges now from our medical oncology colleagues is that they're trying to study and figure out when to start the immunotherapy and at what stage, because we've always reserved these therapies for advanced stage treatments, right? When people have stage 3, stage 4. And so I would say the exciting thing now is we're seeing it even in stage 2 patients where we're giving them immunotherapy prior to surgery. We're shrinking tumors and then allowing us to do lesser resections or at least getting them to surgery where they wouldn't be able to go to surgery prior to. So that's the exciting kind of fusion between medical oncology and surgery that we're seeing. All right, I found out actually Dr. Clayton, I think recently did a coffee connection, but I'm gonna point out some radiation therapy things that she may have already found out, you may have heard from her, but radiation therapy is absolutely used in lung cancer. The way radiation works is it uses high energy beams that basically target the DNA in those cancer cells, causing damage, and then that causes the cancer cells to die. There can be collateral damage, if there will, into healthier cells, but generally speaking, it's not so much like traditional chemotherapy where it systemically affects things. It's pretty good as far as the collateral damage. The other, I'd say, great thing about radiation is it's not invasive. So you go into your radiation therapy, you lay down on the table, everything's planned out for you and the prep and everything that's done before. You get your radiation, which is basically like a fancy x-ray. You don't feel anything, there's no pokes anywhere, and then you're on your way. There are different types of radiation. I would say the one most pertinent for us for lung cancer is the third one mentioned, that SBRT, or stereotactic body radiosurgery. Essentially, what that is, it is high-dose radiation that is very focused and very narrowed in around where the tumor is. And this radiation can be completed in 4 or 5 treatments. And so you start on Monday, you're done by Friday, and you're done with your cancer treatment. And so in the right patient, it makes a ton of sense. And radiation, especially for this SBRT radiation, for very early stage cancers can be very, very effective. As a surgeon, the way I think about this too is, those patients who maybe do have poor lung function or poor mobility issues, or where surgery just maybe isn't the best idea, radiation makes a ton of sense, and I think it absolutely helps our patients. There we go. Okay, so now for some thoracic surgery. All right, so the lungs are, let me just start with some basic anatomy. So most people, we have 2 lungs. We have a left lung and a right lung, and then the lungs are then further divided into what we call lobes. And so the right lung has 3 lobes, upper, middle, lower, and then the left lung only has 2. So a lot of folks don't realize that when I meet them and we start talking about lung anatomy, so I just wanted to point that out. And then when we talk about removing part of the lung, you can take out different parts. So you can do a wedge resection, which is what we would call non-anatomical resection. You can do a segmentectomy, which is a sublobar but anatomical resection. And then lobectomy and then pneumonectomy means we take out the entire lung. Okay. Some of the things I want to point out, this slide shows that the movement in thoracic surgery really, this goes back to 2013. You can see back then it was about 50-50, whether people were having minimally invasive lung surgery or what we would call maximally invasive lung surgery, which would be, as I'll show you in the next slide, a large incision on the side of the chest. And I would say you can clearly see the trend over the 20 teens to where minimally invasive surgery is gaining more and more reputation. And I would say now, I would say our last analysis of this was a couple years ago, but over 99% of our stage 1 lung cancer patients that have been in our hospital are done robotically. So I would say thoracotomy, or the big incision as we call it, is still needed in rare occasions, but rarely done. And this picture just highlights that. So these are basically the 3 different approaches we can do for lung surgery. So open surgery is what I was referring to as a thoracotomy. So this is kind of the old school way that everything used to be done, which would be a big cut on the side of the chest where we actually have to split some of your ribs to spread your ribs. That usually meant about 5 to 7 days in the hospital. Recovery could be anywhere from 10 to 12 weeks. And many more patients with chronic pain after this type of surgery just because of the nerves in the chest wall. Moving on, there was the kind of era of what we call video-assisted thoracoscopic surgery. That's called VAT surgery. That would be akin to your laparoscopic surgery, where still small incisions. You still needed a slightly bigger incision at the top there, but overall, definitely an improvement over thoracotomy. And then finally, evolving to the robotic or Da Vinci surgery, which you can see there, basically 4 or 5 small incisions, everything's between the ribs, and people are leaving the hospital sometimes next day, sometimes 2 to 3 days later. I think this is one of the big slides, I think, especially for our community here, is where do people go after they leave the hospital? And I think everybody wants to go home, or wherever they, where you work, where your home is, right? And you can see with open surgery, basically it was 50-50. So 50% of people were going to some type of care facility, only about a little more than a third were going home independently. And then you can see another 13-15% had some type of aid. And that's when we were doing thoracotomy, or those bigger incisions. And you can see with VATS and minimally invasive surgery, how that's kind of flipped the script now. So well over, I'd say easily it's over 80% now. People are going home independently. They are not needing any aid or home health or anything like that. And it's pretty rare when somebody needs to go to like a rehab hospital or anything like that after even very major lung surgery. The next couple of slides, I was going to actually take everybody through a couple of cases. These are real life cases that I'm hoping to kind of see how we apply some of the technology that we use in lung surgery. So this lady, I believe she was in her 60s, had this spot in her lung. And I don't know if you can see that. Yeah, there you go. You can see this spot here. We would call that a ground glass nodule. And so there are different types of nodules. That's just one of many things. I didn't think I had time to cover everything, but a ground glass nodule is not a solid nodule. It has this kind of smoky appearance in the lung. And this had been growing. It had been biopsied a couple of different times. All the biopsies were inconclusive, but it kept growing. And so we were all very concerned about it. And so this is alarm. Sorry, I heard some moaning. Maybe there should have been a warning shot. I apologize. Everybody got their breakfast down? Okay, all right. So we took her to surgery, okay? And so as a thoracic surgeon, I challenge all of you to look at the picture and find where the nodule is. Does everybody see it? I don't see it either. So I would say I don't know where the nodule is either. So if I'm a surgeon in the operating room, that's a problem, right? If I can't find where the nodule is, what am I going to do, right? And so luckily we have enough forethought. Where is it, right? Luckily we have enough forethought in the situation to figure out, okay, I'm not going to be able to find this nodule. How can I find this nodule? And that's when we call our interventional pulmonary colleagues, Dr. Shaw and his colleagues, and they get their fancy ion robot, right? The same robot I was discussing earlier where they can do biopsies. And Dr. Shaw, you can actually see these are action shots. He's driving the robot right out to where that lesion is. And so he left two things for me. He left this little metal coil right where the lesion is. And the other thing he did, he injected some ICG. It's basically a fluorescent dye. And our robot cameras in the OR are equipped with this, what they call Firefly technology, where it's basically I have a black light imposed on top of my regular white light camera. And so that same picture we were just looking at, let's take another look, and there it is. So, as surgeons, we need the dotted line, so I need to know where to cut, right? So, and that shows us exactly where to cut and where the lesion is. So we did the wedge resection. The other thing we do, we take an x-ray once we get the wedge resection of the actual specimen. You can see the metal coil he left for me. And then we did it, and we did. And this was in this lady's favor. It was what we call adenocarcinoma in situ, which is basically precancerous, literally the last step before it turns into cancer. Excuse me. Also took out all of her lymph nodes that were pertinent to that part of the lung, and you can see her margins were negative. So this is a great case in that patient rolls into the operating room with an unknown diagnosis and rolls out with a diagnosis, staged, because we did all the lymph nodes, and cured. She does not need chemo, she does not need radiation, and so that is a feel-good case for sure. This was found incidentally, just by our primary care doctor. It had been followed for actually multiple years. So a lot of people have lung nodules here in Arizona. It's very common, valley fever, that kind of thing. And so this had just been followed by her primary care doctor. And they noticed that it had slightly been growing, just very little by little, until we finally, somebody decided to start chasing it. So I'm happy to answer more questions. This is the next case. So this is a really, really interesting case. So I know you folks probably don't look at chest x-rays often, but you can probably tell something is not right on that chest x-ray, right? Yeah. So this is a gentleman actually came to us from the VA. Young guy, he's in his early 50s, big motorcycle rider, and he had a bad cough. He was coughing, actually started coughing up some blood, and presented to his doctors there, who eventually got scans. You can clearly see the problem there on the right side of his lung. And so he got CAT scan, PET scan, which you can see here, and this is a very large lung mass. I mean, you can see that, it is huge. And then the PET scan, you can just see how bright that thing glows. What you can't really appreciate, I don't know if you appreciate this little vessel coming around here, and I say little vessel, that's your superior vena cava, right? So that is all the blood supply from your half of the body coming back to the heart, and this mass is basically just touching it, right on top of it. And so this is a classic situation. This is a complex situation, right? So as a surgeon, I don't want to just take this guy straight to surgery. The right answer is we had a multidisciplinary discussion as a team, myself, the medical oncologist, the radiation oncologist, pulmonologist, pathologist, and so we all talked and had our tumor board discussion and decided, chemo makes a lot of sense first. And he actually got chemo and immunotherapy, and then surgery after that. And so I would say, 10 years ago, 9 out of 10 times this gentleman would have had a thoracoscopy. I'd say nearly 100% of the time, with a mass that large. But given the immunotherapy, the chemotherapy, this is a classic case where you can now see this is the surgery. You can still see all the scar tissue around the lung, kind of to his chest wall, but I was able to do this successfully robotically, did a robotic right upper lobectomy, basically also had to kind of peel it off the vena cava, but overall, he left the hospital post-op day 2, whereas he would have been in the hospital for a week. He was back riding his motorcycle 3 weeks after surgery. And so this was a guy who was facing, didn't even know if it was operable, didn't know if he'd ride his motorcycle again, and at minimum had a huge scar with chronic pain and left the hospital in 2 days. So that was another really great feel-good story. I think I'm doing okay on time. This is my kind of, that last case I think really demonstrates, the benefits of having a multidisciplinary care team. And I think that's one of the things, if I could highlight what we do at Banner MD Anderson, is is just that. And so every Wednesday we have, Boswell Hospital has a tumor board where we discuss all kinds of cases, but specifically our lung cancer cases are all presented at that tumor board. What happens after that tumor board is our patients who are coming in to see us in our clinic go up to our multidisciplinary lung cancer clinic. So in that one clinic visit, they see a surgeon, they see a medical oncologist, a radiation oncologist, they see a social worker, they see a psychologist specializing in oncology, all in one visit. And so what this slide demonstrates is what I think probably a lot of people experience. I know I've experienced it as a patient, which is kind of running all over town, right? You go to your primary care doctor, you got a problem, your primary care doctor might order some tests. Oh, we found a lung nodule, let's send you to a pulmonologist. Pulmonologist looks at you, okay, we need a CAT scan, let's get a biopsy, you get those tests done, you go back to the pulmonologist to get results, another week goes by. Pulmonologist says, oh, might be cancer, now you need to see a medical oncologist. Okay, let's send you to the medical oncologist. Medical oncologist orders a PET scan, maybe a brain MRI, maybe some PFTs, and said, oh, you need lymph node staging. You get all those tests done, you go back to the medical oncologist, another week or two goes by, get those results, and finally the medical oncologist will call the radiation doctor, the surgeon, etc. You wait another week to get into their office, and next thing you know, we're 4, 5, 6 weeks out from the initial presentation. And I think this highlights, I don't have a recent study, but I know a couple of years ago there was a study out that showed the time from diagnosis to treatment of lung cancer in some parts of the country was as long as 6 months, which is insane. I mean, that is absolutely crazy. And so what we try to do is really expedite that. Okay, so sure, somebody's got to send you to us, or somebody has to be alert of the problem, right? So that whether that's your primary care doctor, your pulmonologist, wherever it may be. And then basically, if you can get into our interventional pulmonary or our lung nodule clinic, basically we have an APP provider who sees patients and basically gets everything ordered at one time, right? So a lot of times that might mean you need the biopsy first. And so clearly we have to have something to run with and make sure it is what it is. But then after the biopsy, that same point person will order your PET scan, MRI, PFTs, EBUS, cardiac clearance, all that stuff gets done. And then you come to see us in our tumor board multi-D clinic on Wednesday at Boswell, and you see 3 providers, a social worker, and an oncologist in one visit. You don't run all over town. We all come to you, and you leave that day with a treatment plan. And so that's the vision, and that's what we're really trying to push, and that really tries to consolidate that treatment time from that 6 months down to, it should be less than 6 weeks is what we shoot for. So, okay. And I think so this is the team. So Dr. Clayton is our radiation oncologist, Dr. Dave is our medical oncologist, specializing in lung, and then Dr. Broussard and I are the 2 thoracic surgeons over at Boswell. Yes, Broussard and Broussard, we get confused a lot sometimes, but he's about a foot taller than me, so if you see the tall guy, it's Broussard. And I think that's it. Yeah, so hopefully that was a quick overview. I'm sorry if I didn't talk too fast, but I'm more than happy to entertain questions and any comments. Sure. Yeah. So the question is, what about secondhand smoke exposure? I'd have to talk to my pulmonary clinic. I'm not aware of any secondhand exposure that would actually qualify you for the free, like the government kind of paid for lung cancer screening CT scan. So I'm not aware of that, and if anybody else knows otherwise, I'm not aware of that. Yeah, that's a great question. What I would do in that situation is try to have a very, I don't know, your primary care doctor, I assume, or a pulmonologist, I don't know who's managing this for you, but I would try to have a very real conversation with them about your concern and, how anxious you might be about this, given your family history. And just express to them that you would like a CT scan. As far as whether or not, they can order it, it gets paid for, I'm not telling you to take a cough that day. I'm being facetious, obviously. But I think as medical providers, we have to work within the parameters that we're given to work with. But I would say I always want to be an advocate for our patient, and I think there's a way you could probably get it done as far as getting a CT scan if you have that conversation. Yeah. Well,
I just got the letter yesterday, which was shocked.
Turned down by the provider or the insurance company?
By insurance.
Okay. I'm very sorry about that. I personally also fight with insurance companies, so I don't want to turn this into this could easily get off the rails real quick. So in full disclosure, I do peer-to-peers and have to talk to insurance companies all the time. And so maybe that's something you could revisit with your doctor to say, hey, could I request a second, an appeal with your insurance company? That might be a route to try.
Questions. First, with the VATS and the Da Vinci procedures, do those patients need a chest tube afterwards?
Yeah, so that's a great question. I didn't get into all that. But so I would say a chest tube is pretty much used pretty much all the time with any type of lung resection surgery. And the chest tube, if anybody doesn't know, that's a tube we place at the time of surgery, so you're asleep. And you wake up with it, and it goes into your pleural space around the lung, not in the lung. The tube is there to protect the patient, right? And because anytime you manipulate the lung, the general way we cut the lung and seal the lung tissue is with these fine cutting stapler devices. And those tiny microscopic staples need to get airtight. While we're waiting for them to get airtight and heal, you could leak some air. And that can actually be a very normal part of lung surgery. But that tube is there to protect you, because if you leak air, we want that air drained out of your chest so it doesn't collapse your lung, okay? And so, like I know for us, lobectomy patients, 80% of our patients go home in 2 to 5 days, and that's because the chest tube is the rate limiting step. So you're waiting for that air leak to heal within 2 to 5 days. So the short answer is yes. I'd say anybody getting some kind of chest. There are rare cases where we do a non-lung surgery where we could get by without putting a chest tube in. But for lung surgery, everybody gets a chest tube.
Excellent.
Good
The
question.
second is on the immunotherapy,
Yeah.
so interesting. I wondered a couple things. One, are there any side effects and any contraindications to someone being able to get that? And then kind of two, what's the normal course of how many treatments?
Yeah. So once again, my disclosure, not my specialty or expertise, but I can tell you a couple of things. There are contraindications, and most of those revolve around either autoimmune disorders, right? Because if you're already having an autoimmune issue and you're going to give somebody immunotherapy, you can see how that could cause some problems, right? Also in, let's say, transplant patients, you might be on immunosuppression therapy, right? So that's another indication where it would be controversial. And so those are the two main ones that I can think about. As far as course, they are usually infused monthly or in like a 3-week interval. Most of the immunotherapies I'm aware of are infusion, so that doesn't necessarily mean you need a Metaport, by the way, or we can get into that, but port access, some people just can get them peripherally. It's not as spike toxic, or just a peripheral IV. It's not as toxic to your body as the traditional chemotherapies where a port is usually preferred. And then the last part of your, long-term interval. They are usually long intervals. So like I know, usually it's a year at a time. It's not in weeks or months, but a lot of times it's like a year of treatment. So that might be like 12 treatments over the course of a year. Yeah, and once again, that's my surgeon disclosure. Yeah, there are lots of variations of that.
Is the tumor board process at Boswell for all types of cancer or just lung cancer?
Great question. We do welcome all types of cancer to that tumor board. I would say there are occasionally none, but I hate to say it is kind of dominated by thoracic oncology, but it is open to any provider who wants to present or bring a case to the tumor board. Yeah, great question. Once again, I'm going to use the slight disclosure again, not my expertise, but SBRT is your traditional, the mechanism of the radiation is like your traditional radiation. It's just a higher dose and shorter interval radiation, if that makes sense. Proton is a totally different source of radiation. So, and my understanding of the way proton is usually used, it's for even more, so SBRT is very precise. Proton's even more precise. And so it's when you're radiating around really critical structures that need literally millimeter type precision. that's when proton therapy is more effective. There may be other indications, and I apologize, I know it's not something I treat, but
I understand. Proton is very well, but
yeah.
That's what it is.
Yeah.
But again, just take your health care in your own hands.
Yeah.
Don't necessarily.
Yeah, absolutely. And these ground glass lesions, like you spoke about, are very common, and they can be very, if they're going to be cancer, they can be very indolent cancers, meaning they can be very stable for many years and have slight growth. A lot of those ground glass cancers are usually the adenocarcinoma, lipidic type, that's getting a little bit into the weeds, but those are usually very slow growing, and most of them are usually very early stage. So
I'm getting my CT scans even after the 5 years.
Absolutely. Yeah, absolutely. Yeah, good question. So, I'm a cardiothoracic surgeon. Funny enough, you asked me about pancreatic cancer. My NIH research time was all on pancreatic cancer. So, pancreatic cancer usually falls under the surgical specialty of surgical oncology, where it's a general surgeon track that then they do more advanced training in pancreatic and usually biliary and liver surgery. It's kind of all grouped together. And so from a surgical training standpoint, I don't do pancreatic surgery, pancreatic cancer surgery, but we do have two colleagues over at Boswell, Dr. Ramanathan and Dr. Yanala, who are expert pancreatic surgeons. That's really the main thing they do. So that's how that's separated. Yeah, so unfortunately there are some types of cancer, and I can speak, like I said, for the thoracic cancers that don't really present with a lot of symptoms, or when they do present with symptoms, it's very late. And I would say, I can't speak for what kind of cancer your friend's talking about, but or has, but for us, I know we see that in esophageal cancer, right? And so there's no screening test for esophageal cancer. People can have reflux or no reflux, but then all of a sudden they have difficulty swallowing. And what people don't realize is when you have difficulty swallowing as a presenting symptom in esophageal cancer, 80% of those patients are at minimum stage 3. Okay? So that's a similar kind of anecdotal kind of story to what you're describing is by the time you present with a symptom, it's already advanced. And so that, I'm sorry to hear about your friend, but that's, you know. So you're talking about people who have had a resection and then have recurrent symptoms. Yeah. Unfortunately, that is actually pretty common in thoracic outlet for neurogenic type, I assume is what you're talking about. And so the short answer is yes, it can be just scar tissue in that area because surgery causes scar tissue. We try to, when we do that surgery, we try to minimize the scar tissue the best we can, but it's not always possible. I would say you asked about a second rib involvement, or
right. So
yeah.
Is it most likely just the scar?
Yeah, it is rarely the second rib that is involved in that compression. I'm happy to talk to you. We can have a whole side conversation about the different types of techniques in surgery and stuff like that that can affect that. But the short answer is no, it's usually not the second rib. It's usually related to scar tissue, and unfortunately sometimes just nerve damage over time, which just can be unfortunately unreversible. Yeah. What else, sorry?
How often do you see lung cancer in people that have been non-smokers their whole life?
That's a great question. So we unfortunately see it fairly often. It's still, the most common presentation is still somebody who has a smoking history. But if you look nationally at the numbers, the incidence of people smoking is decreasing. And so people with lung cancer and smoking has actually been decreasing as well. But if you look at the overall lung cancer statistic, it's been kind of steady. It's only maybe slightly decreasing. And that's because it's increasing in non-smokers. And unfortunately, you know, I don't have any studies I can quote for you off the top of my head, but in females in particular, non-smokers. And even if you want to go further in ethnicity, Asian female non-smokers is one of the highest presentations of non-smokers, actually. And that's because there could be other genetic things involved that we don't know about. There could be other exposures that we don't know about. Like people don't often think about radon exposure, which is an inert gas that can be in basements and kind of places that don't have poor circulation. Those types of things can increase your risk of lung cancer. Environmental exposures, other things like that. But yeah, that's a great question.
And then now with a lot of people vaping, is that a kind of a risk factor?
Yeah, vaping is bad in many ways. I would say it's probably too soon to know what the long-term effects of vaping are going to be, right? Because that's really in the last decade kind of a phenomenon, I would say. We are definitely seeing acute lung injury from vaping. So people presenting with collapsed lungs, diffuse kind of pneumonitis, things like that, where people are absolutely causing damage to their lungs. I don't know that I can think of direct data that's correlating directly to lung cancer. If you're asking my bet, yeah, it's not good, and so it's going to cause some harm. And I think in the long term, we're going to see some increased lung cancer for those people as well. Any other questions?
Is there anything new on the horizon?
Yeah, so I can speak on the surgical side of things. Advancing the robotic technology and getting even smaller incisions. So there are some people out there, and the Da Vinci system does have a single port robotic system where essentially one incision. I don't know, we can go into like, I have not my doubts by any means, but that incision is probably the accumulation of all four of the other incisions, so it's a little bit bigger, but they're continuing to improve that technology to where eventually we want to do less and less invasive surgeries. I know on the medical oncology side, a lot of it is what I was mentioning is when do we implement some of these new therapies, meaning sooner and sooner in stage 2, and that allows more access. You have to do all these trials to then get the insurance companies on board to then approve the treatment processes, right? So all these things have to be studied and kind of proven that they're helpful. I know in oncology in general, one of our colleagues over at the Gateway campus, Dr. Ulrichsen, is big into the CAR T-cell therapy, which is, I'd say, been transformational for a lot of different like lymphoma-type cancers, leukemias, things like that. So they're talking about how that kind of technology can be implemented in lung cancer and other types of cancers as well. And so, yeah, I'd say, there's always a quote, it's never, now is the best time to kind of be alive because it's only getting better and better. And I know it's kind of hard sometimes with the news cycle, but in general, as it comes to cancer therapy, things are really moving in the right direction and are exciting. So, yeah.
I quit smoking about 50 years ago. What are the chances that my smoking back then was the cause of my cancer?
You quit 50 years ago? And so how long did you, sorry, I don't know. You're asking me. So.
Probably a pack a day for 6 years, 7 years.
Yeah. So I can't quote you the exact statistic, but there is a decrease over time since you quit of kind of decreasing the risk, but the risk never goes to zero as if you had never smoked. Does that make sense? So I don't think anybody can tell you that it had nothing to do with your smoking. Does that make sense? So it never goes to zero. Yeah.
Do you think that sometime in the future that people that have transplants will be able to get immunotherapy?
Yeah, no, that's a great question. I would say my hope is yes. I think the tricky part there is having the body be able to recognize self and not self in that situation, right? Because you have some part of your body that is not you, right, which is a transplanted organ, and you're taking those immunosuppressant drugs. So essentially, they're going to have to get one day, maybe when we have organ transplantation, where we're, I hate to say, growing our own genetic identical organs in, let's say, a pig, and then you could literally put my own kidney back in me. That's genetically my kidney. And I know that sounds like space age, but that's actually being done and tested in like hospitals right now. Back at UAB, they have their robust transplant program where they're doing xenotransplantation. And actually, I think this last year they had a couple of pig-grown organs transplanted in patients just this last year. I want to say a heart and a kidney at UAB. Don't quote me on that. So.
I've read
something
that
Yeah, I'd say this is all super preliminary, but you imagine that's going to be the key where you don't need the immunosuppression, so you don't have to fight your own immune system to kill your new organ. I think that's going to be the hard part. All right. Anything else? All right. Thank you, everybody.